Thank you so much for having me, and thanks for the nice setup in the last talk. So we're going to shift to talking about opioids at discharge, and I'll share some of my research on both opioid prescribing and opioid consumption, and then hopefully prompt discussion of what thoracic surgeons can do in light of the opioid crisis. I have no disclosures. So back in January of 1980, a very short letter was published in the New England Journal of Medicine. And many people believe that this is the letter that sparked the contribution of prescription opioids to the opioid crisis we have today. This letter concluded that despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. Of course, now, almost 40 years later, we know this isn't true, and opioids carry real serious risks both to surgical patients and to society. Two of these risks include opioid dependence and opioid diversion. We'll start by talking about opioid dependence. So the literature shows that of opioid-naive patients presenting to surgery, roughly 1 to 30%, depending on surgical procedure, become longer-term users or dependent on opioids. But this really varies across surgical specialty and procedure. So what about thoracic surgery? Well, those of you who attended STS earlier this year may have seen this abstract out of the University of Michigan, and I understand at least one of the co-authors is here today. It was also mentioned previously today. They found that 1 in 7 lung surgery patients is at risk of opioid dependence. And their publicity stated this research highlights the role of surgeons in reversing the rise in the opioid epidemic. So I'm going to show some results from this abstract. They looked at new persistent opioid use following lung resection in over 3,000 opioid-naive cancer patients who underwent lung resection, and they used a large private insurance claim database, Truven Health Market Scan, for a number of recent years. Their outcome was new persistent opioid use, which was defined as continued opioid prescription fills between 90 and 180 days following surgery. Again, they found that 1 in 7 lung resection patients became new persistent users of opioids, but they found this varied by approach. It was also discussed in the last presentation. So for open procedures, this rate was 17%, but for minimally invasive procedures, it was roughly half, or 9%. So surgical approach affected new persistent opioid use, but so did a number of other patient factors. First, whether or not the patient had postoperative chemotherapy or radiation. The odds ratio shown in their abstract was 2.3. Other important risk factors were postoperative length of stay, or 5 or more days, male sex, age under 64, patients residing in an area with a median income of less than $70,000, and past history of substance abuse, although I believe this final one was not statistically significant. So our patients are at risk of opioid dependence. But opioid diversion is somewhat under-recognized risk of opioids prescribed to your patients, and something I'd like to discuss next. So diversion of unused prescription opioids. We know that surgeons prescribe over 10% of all prescription opioids. So 10%, it's a good number. It's not a super high number, but a lot of these opioids are prescribed to patients not currently taking opioids. So they're the first contact a patient has with opioids. And further, we know that over 60% of opioids that are prescribed to our patients after surgery go unused. Further, these opioids are rarely disposed of appropriately. So everyone has leftover medications in their cabinet. Who cares? There's leftover opioids. Well, these do matter. The majority of non-medical users of opioids access them through prescriptions that were given to their friends or family members. So those leftover opioids many of us have in our medicine cabinets are available for non-medical use of opioids, and again put our communities and our children at risk. Further, up to 75% of heroin users report being first exposed by prescription opioids. So next, are opioids overprescribed for surgical patients? So I think almost everyone knows that, yes, they are, but I'm going to show you some data from a paper my team published last year in Annals of Surgery, Wide Variation in Overprescription of Opioids After Elective Surgery. For this project, we looked at adults who underwent one of 25 common elective procedures across 3 years in the 3 Mayo Clinic main hospitals. We used our institutional ACS NISQIP data, and we merged it with our institutional pharmacy data. From the institutional pharmacy data, we combined all of the opioids prescribed to the patients and converted it into one number of oral morphine equivalents prescribed to our patients. We further compared it to the state of Minnesota draft guideline of 200 oral morphine equivalents maximum, which was being considered and is still somewhat being considered right now following major surgery. And 200 oral morphine equivalents is about 26 to 27 tabs of 5 milligram oxycodone. The 25 elective procedures are listed on the right-hand side of this slide. Unfortunately, for today, only one of those was thoracic, but I will be showing you those data in detail later. It's a VATS wedge resection. So for the total cohort, we had over 7,000 adults who underwent one of our 25 procedures. The median age was 64, half were female, about 2/3 were inpatient, and almost everyone had general anesthesia. Because we included inpatient and outpatient, our median length of stay was only 1 day. In total of these patients, 94% received opioids at discharge. Only 6% did not receive an opioid at discharge. The median prescribed is 375 oral morphine equivalents, or about 50 tabs of 5 milligram oxy. In total, over 80% of our patients received in excess of the state of Minnesota draft guideline of 200 oral morphine equivalents. We then compared our opioid naive patients to those who present to surgery currently taking opioids. And of course, we saw a difference. The median prescribed to the opioid naive patients was still 375, or about 50 tabs of 5 milligram oxy. But for the preoperative opioid user, the median prescription was 600 OME, or 3 times what the state was telling us they were considering as a maximum. The rest of our analyses focused on our opioid naive patients, which was about 3/4 of our cohort. I will take some time to go through all of the detail on this slide. So each of the columns is one of the 25 procedures. On the left, we have the amount of oral morphine equivalents prescribed from 0 to 1,400, but note the top of this chart is truncated. It went up to 30,000 and above. On the right, these have been standardized to 5 milligram tabs of oxycodone from 0 to 200. From what's visible, again, it went much higher. This dotted line shows the threshold of 200 oral morphine equivalents as proposed by the state of Minnesota. And for each procedure, the black line represents the minimum to the maximum amount prescribed, with the blue box representing the inner quartile range. So the median for each procedure is somewhere within the middle of that blue box. In total, only 3 of our 25 procedures had medians prescribed under 200 oral morphine equivalents. The other 22 procedures all had medians at least 200 or above. In total, again, over 80% of our opioid naive patients also received more than 200 oral morphine equivalents. Focusing in on our VATS wedge resection patients, 91% of them took opioids home. This ranged from 0 to 1,800 oral morphine equivalents, with the median being 562, yet only 9% received refills, which was on the lower side. I'd like to just point out again the huge variation, and these are in opioid naive patients. So that project showed us how many opioids are being prescribed to our patients and suggested perhaps we need some standardization. But in order to understand the optimal amount to prescribe to patients, we need to know how many they're using and how many are left over. So for that initiative, we launched a survey of 2,500 recently discharged surgical patients across the same 3 centers. Again, our goal was to determine how many opioids were used from the amount of opioids we already knew were prescribed. These data will be presented in full next month at the American Surgical Association. So unfortunately, I can't show you our final data, but I am able to share the data that's been published in the abstract on the Society's website. So in total, 63% of the opioids our Mayo Clinic surgical patients took home were not used. Further, almost a third, 31% of our patients used 0 opioids. Only 10% of patients disposed of the remaining opioids, so most people are keeping them at risk of being diverted to other people. We also asked a lot of questions about patient satisfaction. Whenever we work with a new surgical specialty on developing guidelines, they're always worried about their patient satisfaction, rightly so. We want our patients to be satisfied overall with their care and how their pain is managed. So we asked a number of questions about patient satisfaction, as well as questions about accessing refills and how easy it was for the patient to get refills when needed. So in total, 91% of our patients were satisfied with their postoperative pain control. We also asked patients how they felt about the amount of opioids they were prescribed. 28% reported being prescribed too many, with a handful or 8% feeling they were not prescribed enough. This is the figure from the American Surgical Abstract. There's 25 procedures shown here. The total width of the bar is the amount of opioids prescribed, ranging from 0 to 600. So this is the median amount prescribed. The blue proportion is the median amount consumed. The orange proportion is the median amount remaining. So you can see for almost every one of the 25 procedures, the blue proportion is much smaller than the orange proportion, demonstrating how many opioids are left over. We had 2 thoracic procedures in this initiative, open lung lobectomy and MIS lung wedge. You can see that for both of these, the amount consumed was less than half of the amount prescribed. Interestingly, in our abstract data, lung lobectomy were both prescribed and consumed fewer than MIS wedge, but in our final data, this was reversed and makes more clinical sense. We also, again, looked at the amount of patients who took 0 opioids, and for the open lung lobectomy, 10% of our patients took 0 opioids after surgery, but for MIS lung wedge, it was 27.5% of patients did not take any opioids after discharge. So I've shown you a lot of data. Our goal is to improve practice, or if we think about the title of my talk, what can thoracic surgeons do? So first, talk to your patients about opioids. Talk to them about pain expectations, what they should expect in the postoperative course. Talk to them about dependence and diversion. One of my colleagues now counsels his patients and says, your risk of infection is X, your risk of opioid dependence is Y, and we're going to do everything we can to ensure that you don't experience either of these adverse events. This came up in the STS abstract that has been talked about in the prior talk, where it's similar to the risk of atrial fibrillation. So this is something to be discussed with the patients. And my surgical colleagues tell me that patients are often bringing it up more and more now as well, as you may have experienced in your practices. Also, talk to them about diversion or see what's happening in your institution with disposal options. Patients can flush their pills down the toilet. The FDA does say opioids may be disposed of through the toilet. Some patients don't want to do that, and there's other options as well. But talk to your patients about how to get rid of leftover opioids if they exist. Also, standardized opioid prescribing. These huge ranges just do not seem to be optimal. So to do that, I suggest reviewing your prescribing and consumption data, discuss with a multidisciplinary team. Every one of our initiatives at Mayo Clinic has had a surgeon champion, a data scientist, me, nursing, pharmacy, and some other quality colleagues to develop and implement these guidelines and develop recommendations for best practices. So first, review your practice's opioid prescribing. At Mayo Clinic, the surgeons are often not the ones actually prescribing, and that may also be occurring at your institution, where it's really the trainees, the residents, the fellows, and the NPs, PAs who are doing the prescribing. So be aware of what's being prescribed to your patient and who is doing the prescribing. Also, for refills, again, refills is something that's constantly brought up to me as a concern. People don't want phone calls for refills. They don't want their patients to have problems getting refills. However, the literature shows that the initial amount prescribed at discharge is not related to the refill event. Think about what amount should be prescribed. If you're able to, assess your patient consumption, either during follow-up visits or through other means, and then standardize your opioid prescribing for the typical patients. Not every patient will fit into a bucket, and that's okay, but there should likely be a typical amount that's prescribed. And then you can develop guidelines like we have or implement existing guidelines. So I'm going to show you some of the consumption data for the VATS wedge and the open lung lobectomy. So we'll start with the VATS wedge. I think I'm supposed to use this one. Or not. Okay, so the middle column. The range prescribed is 0 to 5,400. The median prescribed is 337.5. The median amount consumed was 90. So median amount consumed 90, median prescribed 337.5. In our open cases, the median prescribed is 450. The median consumed was 300. So this is coming from our roughly 130 patients who completed the survey. From this and many, many, many other sources of data, we've come up with the Mayo Clinic Surgical Outcomes Program recommendations for adult discharge opioid prescriptions. And this is obviously small text here, but it has all of our different procedures on the left. And then we offer 3 potential doses: low dose, standard dose, or high dose, so to see what's best for patients. And this includes both opioid naive and preoperative opioid users. In order to better sort patients into one of these columns, we have factors shown to influence usage after discharge, and I've zoomed in on that, recreated it for this next slide. So patients with certain characteristics on the left may be eligible for standard or lower doses. Patients on the right, standard or higher doses. So the lower doses are patients who present as opioid naive, older patients, lower BMI, cancer diagnoses, which I know may be counterintuitive, lower pain score at discharge, or low in-hospital opioid use. Patients who, through the survey, have been shown to need more are preoperative opioid users, younger patients, higher BMI, non-cancer diagnoses, and then, of course, the higher pain scores or higher in-hospital opioid use. So zooming in on the thoracic procedures included in our guidelines, we first have bronchoscopy. Regardless of where the patient falls on those characteristics, NSAIDs and acetaminophen are recommended. For VATS, the lower dose, remember 27.5% of our VATS patients took 0 opioids after discharge, so some are eligible for NSAIDs and acetaminophen only. The standard dose would be 20 tabs of oxycodone, and some patients have higher needs and may need up to 40 tabs. For thoracotomy, low dose, only 10% of our open lung lobectomy patients took 0 opioids, so most are recommended 5 tabs at the least. The standard dose of 50 and the high dose of 60 tabs. Further, if you're developing your own guidelines or things to keep in mind for your practice would be multimodal pain control, use of NSAIDs and acetaminophen in some patients in lieu of opioids, and in some patients to decrease the total amount of opioids they need to take in the postoperative course. And finally, tapering plans. Our pharmacy colleagues are really working on tapering plans so our patients can understand how to decrease the amount of opioids over time and hopefully not become new persistent users. So in conclusion, the goal here is to optimize opioid prescribing. We want thoracic surgical patients not to receive less medication than they need to appropriately address their surgical pain, but we also don't want them to receive excess medication that could result in their own long-term use or dependence or opioid diversion to others. Thank you very much. Thank you, Dr. Allen, for the invitation, and I'm happy to join the panel.